Good morning and welcome to Surgery Grand Rounds. There is no commercial support. The speakers and planners have disclosed no relevant financial relationships with any commercial interests. You will receive a SurveyMonkey link after today's activity. And if you are American Board of Surgery certified, I will need you to fill out that evaluation if you would like us to report your credits to the ABS board. If you're viewing online, we will list that link into the chat section. And if you have a question, we'll hold until after the presentation is over. It is my pleasure to introduce Dr. Darrell Hunt. Dr. Hunt completed medical school at the Washington University School of Medicine in St. Louis. He then completed his residency in general surgery, PhD in molecular cell biology, and fellowship in surgical critical care at the University of Florida in Gainesville. Dr. Hunt was named the Trauma Medical Director of TriStar Skyline Medical Center in Nashville, Tennessee in February of 2021, and the Division Trauma Medical Director for the TriStar Division of Hospital Corporation of America in 2022. He is also the Program Director for the TriStar Nashville Surgical Critical Care Fellowship, which started in 2023. In his free time, Dr. Hunt enjoys spending time with his wife and 2 children. Join me in welcoming Dr. Hunt.
Good morning. I'm Darrell. I'm from Nashville, run the trauma from the Chief of Trauma at TriStar Skyline. So happy to be here, honored to be here. I met Dr. Nelson Royal at the American College of Surgeons as Educators course, and we actually are trying to work with you guys from the trauma program standpoint to do some research together. So super happy to be here and super excited to talk to you about this topic. This is basically a topic about hemorrhagic shock and thinking about hemorrhagic shock from a trauma surgery perspective and everything we do pre-OR. So this is not about operative techniques. This is what we do before we get to the OR to try to stop a guy from bleeding to death. Okay, you ready? Listen. Please hire me to do something so I can have some disclosures. I'm happy to take a check and give you some advice about stuff. So look out for me. I'm around. All right. You don't have to worry about the objectives. We'll get there. So this is a real trauma alert that came across my phone. So a level 1 trauma. So that means there's physiologic abnormalities that make it meet the criterion for a level 1 trauma alert. And for this one, it was the guy was hypotensive, right? He's a little bit tachycardic, heart rate of 102, but the blood pressure, right? Systolic blood pressure less than 90. That's when I get excited, right? I see a lot of trauma alerts, right? GCS3, none of that stuff excites me, right? Because all I'm going to do is stabilize that patient, get them ready for the neurosurgeons, get them over to the trauma ICU, get some Keppra going. If they need to be intubated, my ER colleagues and their residents are going to do the intubation, all that stuff. So I don't get excited until the systolic blood pressure is low, right? Because that means it's time for me to do something. I'm going to have to figure out what's going on. I'm going to have to stop the bleed, right? That's why hypotension makes me excited. All right. Here's the classic stages of hemorrhagic shock. We're going to go through these one by one. So stage 1, right? Here's the thing. In a young, healthy person, you can bleed 2 cans of Coke and not have any physiologic abnormalities at all, or 2 cans of Celsius these days, right? Because I kind of live off Celsius. So, right? So just because a young, healthy person's vital signs are normal doesn't mean that they haven't bled or are not bleeding, right? So you see a guy who's all beat up, but all of his vital signs look great. And you're like, there's nothing going on. Well, there may be something going on if they're young and healthy, right? But the first sign, really the first sign of hemorrhagic shock is tachycardia, right? And you got to think to yourself, there's a lot of reasons why our patients can be tachycardic, right? Is there meth around here? There's a lot of meth in Nashville, right? So there's a lot of reasons why a trauma patient can be tachycardic. But if you really think that tachycardia is related to bleeding, then you got to think if their heart rate's greater than 100, that we're already at a liter of blood loss, right? We're already there. If you truly believe that tachycardia is secondary to blood loss. The narrowed pulse pressure. This actually may be more sensitive than tachycardia. So a couple good papers out over the last couple of years. You get that first blood pressure and it's 120 over 100. And you're just like, 120, I'm good to go, right? But that 100, that diastolic blood pressure, the sympathetic activation is going, and now you're moving all of that blood from the lower extremities and the capacity vessels to the effective circulation, right? So you're squeezing down, right? And so that diastolic blood pressure is probably real, and it's probably a sign that the patient is hypovolemic. And for trauma, if you're hypovolemic, that means you're bleeding, right? Oliguric, most of these people don't have a Foley at the beginning, right? So oliguria doesn't really count at this point. 3, right? Stage 3. So the first time you see a blood pressure less than 90, and you truly think that that's related to hemorrhagic shock or that's related to bleeding, you got to think to yourself, this patient's already lost 2 liters of blood, right? Because this is why I get excited. This is why when that guy's systolic blood pressure was 86, I'm like, this guy is 2 liters down, right? He's in class 3 shock. This means I have to do something, right? This means I have to figure out what's going on, and I got to stop this guy from bleeding, right? This is the first time where your brain's not going to be getting enough oxygen, right? At 2 liters, your body is starting to fall apart, right? They start to get confused. You're going to really notice their respiratory rate at this point too, right? Because the respiratory rate of 20, maybe 25, you aren't going to pay attention to that. If a person's breathing 40 times a minute, that's going to be noticeable, right? So if you start seeing these things, hypotension, you really notice that they're working to breathe, right? Those things, if you relate those things to hemorrhagic shock or blood loss, you got to think we're already at 2 liters, right? Above 2 liters, the patient looks like they're dying, right? They're unconscious. This is not going to be someone who's subtle about their blood loss, right? They're going to look like they're dying. There's going to be a pulp, there'll be 60 over palp for the pulses. The patient's going to be in and out of consciousness. This is a person who's going to look like they're dying. So that's the way I approach these patients. When this guy came in, I said, he's bleeding, really bleeding. And how do I figure out where he's bleeding, right? Because that's the first thing for a trauma surgeon is where, right? What's the source of the hemorrhage? So I know he's hypotensive. I think this is related to hemorrhage or hypovolemia. How do I figure out where it is, right? So the sources. You think about the chest, right? You can put 2 liters to 2.5 liters of blood into your pleural space on each side. So you can bleed to death from thoracic trauma. And if you look here, right, all of these important. I love this because this is a great blob, right? I know there are a lot of doctors in the house, but for most people when I teach this is just a big gray blob, right? I don't have one of these because I'm a surgeon. Surgeons don't. Anyway, underneath this gray blob, what this gray blob represents is all this stuff that can kill you if it gets real, right? And so you end up with something that looks like this, right? Now you got a big left chest full of blood, right? I did an ER thoracotomy on a guy probably 2 years ago, and we basically pulled out his entire blood volume out of his left chest. He had 3.5 liters of fresh and clotted blood in his chest. He died, but you can bleed to death from thoracic trauma. So that's one of the places that surgeons think about. Internal organs, right? Hollow viscous injury, not so much. We're talking about solid organ injury, right? So again, CT scans, this is your head's facing this way, your feet's facing that way, and we're giving you thread slices like that, right? This blob right here is your spleen. That's your spleen when it's all broken up, right? These dark lakes of death in the middle of this spleen, right? You can die from that. That's how it might look on a gross specimen. Your liver is also a solid organ that can be injured in trauma, right? So here's your liver right here again. Shades of gray, there's your gallbladder right there. But then what's happening with this liver? There's a gigantic lake of death in this liver, right? This is a grade 5 liver laceration, and this person is going to die unless we do something about it. That's how that might look on a gross sample, right? Big old laceration in the liver. Where else can you bleed? Your thigh, right? Long bone fractures. How much blood can you lose from a femur fracture like that? How much? You can lose 1 liter to 1.5 liters with a bad femur fracture, right? It's the South, big thighs. You might be able to put 2 liters down there, right? That's how it happens. I live in Nashville, so very familiar with Southern physiology, right? So that bleeding, that bone marrow won't stop until you get bone apposition. So reduction of bone fractures are a part of circulation, right? Where else can you lose it? You can lose it in the pelvis, right? Retroperitoneal bleeding. If it's bad enough, both retroperitoneal and intraperitoneal bleeding. I'm going to show you why. It's because, okay, people, listen. I'm about to show you one of the scariest slides in medicine, and you're not going to care. and it disappoints me every time. It's this right here. That's the pelvic vasculature, people. Only 3 of those vessels have real names. All the rest of them are just there for you to die. You're going to rip a vein. You're going to rip a little artery. The corona mortis is down there in your obturator canal. All of these things are just waiting for you to die. They're just waiting to kill you when you have a pelvic fracture. This is my patient. The thing on the left is my patient. So the one we originally started out with hypotension. So this is an x-ray that shows you pubic symphysis should be together right there, right? And then he had a gigantic open book pelvic fracture, right? Normal human anatomy, a normal human can keep about 1 liter of blood in their pelvis. This guy with a fracture like that, we're talking about 3.5 liters of blood down in the pelvis, right? So you can bleed to death from a pelvic fracture. This is off the internet. This is actually not my patient, but I had a patient like this, right? Bullet went straight through his pelvis, right? You can bleed to death. All of those unnamed vessels hanging out around your sacrum, you can bleed to death from your pelvis. Okay, and then we say on the floor, external, right? When I was a 4th-year resident, like by the time you're a 4th-year resident, you kind of think you're hot stuff. You don't need to be attending around anymore, right? You're like, whatever, man, I got this. Stay asleep, bruh, fine, right? So me and my junior resident, we were having a great time on the trauma service. We got a guy, hypotensive, fast positive, straight to the OR. By the time the attending woke up, freaking spleen was on the table, right? The radiologist calls. He's got a grade 5 spleen fracture. We're like, yeah, buddy, it's in the bucket, right? So we're feeling all good about ourselves. We're getting ready to close. And the anesthesiologist goes, hey, man, yeah, man, what you need? I'm a superstar. He said, man, I got blood over here. I'm probably in like a 1/2 inch of blood down over here in my area. I was like, oh, what? Guy had a gigantic laceration in the back of his skull, right? And scalp lacerations will not stop bleeding because of the way the arteries are set up in the galea. The arteries retract and they will just keep bleeding until you do something about it. And so while we got it out pretty quick. So in the 20 minutes, we got the spleen out and we're high-fiving. The guy was still hemorrhaging, right? And the MTP was still going, and it was all because of his scalp laceration. So external, right? On the floor is the 5th place that we think about. So chest, abdomen, pelvis, extremities, and then on the floor, there's something bleeding that you haven't taken account for, right? All right. How do you stop a guy from bleeding if it's external bleeding? What's the first thing you do? You got to hold pressure, right? If you see something bleeding, you just hold pressure on it, right? That's the first thing anyone should do. If it's bad enough that you can't hold pressure, you got to take your shirt off and pack it. I'm not taking my shirt off. You might bleed a little bit. I'm going to just hold pressure. But you find a young, fit person, you say, hey, take your shirt off. And then you pack the wound and you hold a little pressure, right? If packing the wound and holding pressure doesn't work, then you got to put on a tourniquet. Again, all of these things are from the internet. These are not my patients, right? But if you got something like this, you want to go, I know ATLS teaches, just proximal to the wound, but not over a joint, right? I'm still a high and tight guy. So you just get it on there and it should hurt to put a tourniquet on, right? It should hurt to cut off someone's vascular supply to their extremity. So you got to pull that thing and they should scream. And you say, sir, ma'am, I'm just doing this to try to save your life. It's going to be okay, right? You should not have a distal pulse if you put a tourniquet on, right? And the bleeding should hopefully stop, right? But it should be a painful experience for the patient you're doing it to, right? So that's extremity bleeding and how to get control of that. Direct pressure, tourniquet. Pelvic binder. I love a good pelvic binder. Makes me happy. If you read all of the studies on pelvic binders, they will say that pelvic binders don't work, that they don't do anything. Why? Because people don't put them on in the right spot, right? People still doing the anterior superior iliac spine. That's not where you put a pelvic binder. Your pelvic binder should be at the middle of it, should be at the level of your greater trochanters. It should be down here. I always say, if you can see the base of the penis or you can see the cleft of the vagina, you're too high. All of your good parts should be covered if you have a pelvic binder on in the right spot, okay? This was my guy after we put a pelvic binder on. So EMS called us and said, we think he has a pelvic injury, pelvis is unstable. So I put the pelvic binder out on the stretcher before he even got there. And so when we verified that he was hypotensive, we pulled the pelvic binder on, and then you can see a reduction. He still has this rotated bone fracture, but you can see that the pubic symphyses are closer than they used to be. All right. How do we diagnose internal bleeding? What do we use? Use the FAST exam, right? But this one, there's some external, right? You can see that there's something going on, right? There's a couple knives to the belly. This guy has a bullet entrance wound right there. It's very hard to see. He's an African-American male, dark skin, but that bullet wound is right there in the box, right? That's a good place for me because now I got to do a thoracoabdominal operation and I'm all happy at that point. Bruising, right? That's another clue that there may be internal bleeding, right? So there's a couple seatbelt signs for you to see. There's the retroperitoneal signs that we all read about in medical school, the Cullen sign and the Gray-Turner sign. So that's retroperitoneal blood coming around to the anterior space in the subcutaneous tissue, and you get these signs, right? Here's a guy with Gray-Turner's, Cullen's, and Fox's sign, right? So when that retroperitoneal bleed comes down into your inguinal ligament area, that's called Fox's sign. Okay, then you get your FAST exam, right? You got to knock out a FAST exam. Here are the places where the ultrasound goes, right? And here's what we're looking for. We start off wherever you start off. I usually start off in the pericardial area, but this is the right upper quadrant. We talk about blood being in Morrison's pouch. So here's your kidney, and here's your liver, and those two capsules, both your liver capsule and your Gleason's capsule, get together and form this nice a wave opaque line right there. Right? Liver, kidney, Morrison's pouch is what we call that. This is your right upper quadrant view. And then if it's positive, right, that's normal. That's the way it should look, right? But it's positive, then you get a little strip right there. That's fluid. In a trauma patient, that fluid is blood, right? So that's a positive FAST in a hypotensive patient. Depending on where you are, we have a lot of arguments about this in M&M all the time. I'm still kind of old school, where if you're hypotensive in a positive FAST, I take you straight to the OR. We're about split half and half on this. Half of my partners say you can resuscitate a patient just fine, take them to the CAT scan, see if there's something else going on besides something in the abdomen. So we're still split on that. That's kind of a new school thought. I was trained positive FAST, hypotension, you go to the OR, and I still do that. Here's a big lake of death, right? This is a super positive FAST, right? All of this blood separating the liver and the kidney. All right, your left upper quadrant, same visualization, right? There's your, let's go back. All right. There's your spleen, there's your kidney, right? And again, you're looking for blood to separate them. That's how you get a positive FAST. And there's a positive FAST right there, right? Big old lake of death again, coming through, separating the spleen and the kidney, and that's blood, right? So now we've done right upper quadrant, left upper quadrant. We're gonna go down to the pelvis, right? That's not blood, that's your bladder, right? That's water. That's the way your bladder's supposed to look. It'll be urine or water contained within this roughly overweight shaped, circular shaped, distended bladder, right? That's how it's supposed to look again, right? That's a bunch of urine inside the bladder. It's very smooth edges, right? There's a positive FAST, right? So this out here shouldn't be there, right? There's urine, there's the bladder lining, and that's blood in the pelvis. Same thing here, another positive FAST, right? So there's blood down here in the pelvis, there and there, right? All right, how are you gonna stop that bleeding? Before you get to the OR now, or before you get to IR, intervention also helps us with these solid organ injuries, but what can you do before the OR, right? People talk about TXA. You guys use TXA? Yes? Bleeding trauma patients? Fantastic. Let's talk a little bit about TXA and about the literature. Let's first talk about what it does, right? So here's what we think TXA does, right? Remember TPA, the clot busters for people who are having strokes and heart attacks, right? So TPA activates plasminogen and it breaks down clot, right? So what TXA does is fit right here in this little lysine portion of plasminogen. And so it stops plasminogen from activating plasmin and breaking down fibrin clots, right? So you keep more of these fibrin clots that are holding all of these red blood cells together or platelets together, right? So it's supposed to keep your clots stronger, right? That's what TXA does. It prevents your clots from breaking down. Doesn't help you form clots. It just prevents your clots from breaking down, right? So how do we get to TXA? This is the crash study. Listen, if you don't remember anything about this talk, you remember that I told you that short guy from Nashville that crash is trash. It's the worst study I've ever seen in my life. It's terrible. It was done in a very random fashion with people just deciding on their own whether or not they wanted to give TXA. Didn't really have anything to do with anything. They were like, I think he should get some TXA. The difference that it found was 1% difference in death from hemorrhage. If this had an interim analysis in a real study, they would have stopped this study. It's terrible. This is what it was, 274 hospitals, 10,000 patients in each group. That's the only reason it reached statistical significance, right? You can make something that's nothing look like it's something if you enroll enough people, right? That's what happened with crash. Terrible. But we did learn something, right? So even when you dumpster dive, you can learn something. So this is what they did. I can't really tell you, they say that there was criteria for giving TXA, but when you really read the study, people just, if you felt like giving it, you thought they were bleeding, you just give it, right? They gave 1 gram bolus over 10 minutes and then 1 gram over 8 hours. Where does that come from? You know where that comes from? Orthopedic surgery and cardiothoracic surgery. And we don't let those guys tell us anything other than bones and hearts, right? You guys out there, I love you guys. Don't think I don't. I love you guys. But that's where that comes from. And what they show from this, right? They show the risk of death due to bleeding, right? First, 30-day all-cause mortality. What was the difference? 1.5%, right? If I told you were going to give a medication, it was going to make a 1.5% difference, you would laugh at me, right? No industry would sponsor that, right? It would be dead in the water. And if you look at the risk of death, particularly due to bleeding, which is what it's supposed to stop, right? It was less than 1%. The only reason this got published is because of the sample size. The sample size was huge, and it made something that might be clinically insignificant into something that was statistically significant. And now we value statistical significance over clinical significance, right? That's how you get published in JAMA or New England Journal, right? You have statistical significance, right? Terrible study. 84 never needed to treat, right? The absolute risk reduction was 1.2%. You got to give 84 people TXA from this study in order to make a difference in 1%, right? Now, if you're that one person in 100, yes, you want some TXA, but scientifically, not really where we want to be. But we liked it, right? What did we learn? When I say dumpster dive and learn something, what did we learn? Don't give TXA after 3 hours, because you'll actually probably kill the patient if you do that, right? So out of that terrible study, we did learn something really important. Don't give TXA after 3 hours. Then came the Matters trial. Here's how the Matters trial was set up. It wasn't a trial. It was a single forward operating hospital, military. They were giving people TXA if they were bleeding, right? How much TXA? It just depended on how much the surgeon wanted to give. It was anywhere from 1 to 8 grams of TXA, right? Basically, if you kept bleeding, surgeon was like, hit him again, right? Hit me, still bleeding. MTP still going on, hit me, right? 2 or 3 of these patients in the study got 8 grams of TXA, right? No data behind that. Surgeon just was like, I'm the surgeon, give TXA, right? So you're looking at, there we go, 293 patients, right? So they did it in patients who didn't receive MTP and patients who did receive MTP. And here's kind of what they found. Right? So they did the 1 gram bolus and then repeat those boluses per the surgeon's discretion, right? And it had to be done within 3 hours of the injury, right? So here we are. There was no difference in death at 24 hours. At 48 hours, if you got TXA, this is without MTP. So at 48 hours, if you got TXA, mortality was 11%. If you got no TXA, it was 19%. Okay, so we're getting better, right? So the number needed to treat was 14. Then at 15 days, here's the difference, right? So we're getting better, right? TXA is doing something, we think, right? Here's if you actually got an MTP, which you should get an MTP if you're bleeding to death, right? And not TXA alone. So it works better if you're actually getting an MTP, right? So 48 hour mortality, pretty good difference, right? Never needed to treat 8. So I'm feeling a little bit better about TXA at this point from the Matters trial, right? The problem with the Matters trial, again, is there was no control over how how much TXA the patient got. All right, so here we go with the STAMP trial, right? This is our level 1 grade A data, right? This is a multi-institutional randomized trial, right? These 4 institutions, again, they're picking people who are in class 3 shock, right? So systolic blood pressure less than 90 or heart rate greater than 110, right? These are people who are truly in hemorrhagic shock. And that's really when TXA works, right? They were estimating within 2 hours of injury, then they had a pretty good spread between the patients. They gave 3 different regimens of TXA, all right? One group just got a bolus. They got the 1 gram bolus and that was it. One group got the 1 gram bolus and then got the 1 gram infusion. And then the other group got a bolus in the field. They got another 1 gram bolus when they got to the hospital. And then they got the infusion. And so what did we learn from this, right? Only the patients that got the 3 gram protocol actually had a mortality benefit, right? So if you're going to go to TXA, you got to go with a 2 or 3 gram bolus. That's what's going to help you. That continuous infusion after the bolus doesn't do anything. We give a 2 gram bolus for our patients who are on MTP, right? In this study, it was only successful if it was given within the first hour, right? So TXA is something that you want to give fast, you want to give now, and you want to go with the big dose. It only worked in this study for people whose systolics were less than 70, right? So TXA is going to have its most benefit in patients that are bleeding to death from their trauma, right? You want to give them a 2 gram bolus up front. If you want to do the continuous infusion, great, but that 2 gram bolus is really what's making the difference. So here's how you use TXA, right? Early as possible, but never after 3 hours. You go big. You go ahead and give the 2 gram bolus, right? And it's going to work best for your patients who are actually bleeding to death, right? Your patients who are in class 3 trauma, class 3 hemorrhagic shock. So I hear you out there. You say, Hunt, what about the patch study? Just came out in the last year. Patch study says TXA doesn't do crap and that we shouldn't use it. I'm taking it off my protocol. Here's the problem with the patch study. Wrong patients. They picked their patients using something called a COAST score that predicts INR and PTT values. Has nothing to do with trauma. Wrong dose. They were given the 1 gram and the 1 gram infusion. We already know that that doesn't work. And the wrong outcome. You know what the patch trial's primary outcome was? An extended Glasgow recovery scale at 6 months. Whoever said TXA was going to do something about how you walk 6 months from now? Right? You tell me TXA doesn't work because both guys are on crutches? That doesn't make sense, right? That's not what TXA was made for. TXA was made to stop hemorrhagic shock, right? Stop bleeding. So I still think TXA is the right thing to do for our patients who are in hemorrhagic shock, right? That's the story on TXA. What about plasma? That's out there. Are your first responders out there carrying blood or plasma now? Yeah. So they tried it, right? Said it makes sense, right? Why does plasma make sense, right? Well, it's got more clotting factors than Kcentra. It's got more fibrinogen than cryo, right? It's pretty good volume, and the pH is normal, right? Kind of makes sense. Patients bleeding to death, you want to give them something that's going to stop the bleed. They need factors, they need fibrinogen, they need a little bit of volume, right? All these things are going to be good for the patient. What happened? Didn't do squat. Didn't work. No difference in mortality, right? This was a single institution study, right? This was the combat trial. Again, they chose patients who were in class 3 hemorrhagic shock, right? Systolic blood pressure less than 70 or 70 to 90 with a heart rate greater than 108. No difference in 28-day mortality. They did not save lives with plasma. They tried it again, right? The Pamper trial to look at plasma, right? Trying to give people plasma because it seems to make sense. They did 27 air bases, and again, we're looking at class 3 hemorrhagic shock, right? What happened? Nothing. Didn't work. Now, what happens when you get 2 studies that say something didn't work, but you still believe that it works? What do? You put them together, and you do some kind of post hoc analysis, right? I believe in this enough that I'm going to take these 2 studies that say it doesn't work, and I'm just going to add all the patients together, and I'm going to sprinkle some statistical stuff on it, and I'm going to shake it up. and see what happens, right? Post hoc analysis. So they harmonized the patients, which means they put them together, right? Found out most patients died within 6 hours, right? Because if you're bleeding to death, you're actually bleeding to death. And the mortality difference, it only made a difference to give plasma if it was greater than 20 minutes until you reach the hospital, right? So that's when plasma is going to be effective, when you got a long way to go to get to your level 1 trauma center, level 2 trauma center, wherever the best trauma center is around you. That's when plasma has the most effect. If you can get to the hospital in 5 minutes, the plasma is not going to make a difference, right? There's another study to harmonize it, right? And then they realized that it was only for blunt trauma. So how are you going to use plasma? All right, you're going to use plasma if a patient's in class 3 shock, if it takes longer than 20 minutes to get to definitive care, or a trauma team who can take care of this patient, and if it's blunt trauma, right? That's going to help with your mortality, right? Then they started doing other things, right? The cryostat trial. This was patients bleeding to death, standard of care, whether that's TXA or not, and an MTP. This is all going, right? Let's give them cryo up front. Let's give them 3 units of cryo, right? We're going to give them the equivalent of 6 grams of fibrinogen, and that makes sense, right? Bunch of clotting factors, bunch of fibrinogen, patients bleeding. Let's do it, right? It's the cryostat. Let's do it. Didn't work. Didn't work at all. No difference in mortality, right? So giving people a bunch of cryo doesn't work, right? Then people said, okay, we love Kcentra. It reverses Coumadin, right? It's got factors, 2, 7, 9, and 10, 4-factor prothrombin protein complex. It works. We like it. We're going to give it to people who are bleeding to death, right? The ProStat trial. What happened? Nothing. Didn't work, right? So giving them cryo doesn't work. Giving them Kcentra doesn't work, right? If you have a patient who's bleeding to death, you can give TXA, and in the right circumstances, you can give plasma. Those 2 things affect mortality. Cryo and PCC, 4-factor PCC, does not. So now we're back to mechanical obstruction of the aorta, right? We're going to do something to stop blood from going down to the places that are bleeding. This is already out in the field in the military. All trauma surgeon advances during war and military exercises, they're doing this now. So if you have a proximal bleed, sort of pelvic bleed somewhere in there, can't get control of it in the field, they put the belt on you, they squeeze it down, and they compress your aorta. I thought, the GI, the colon, the small bowel, all those things that you're crushing, it's all going to be dead by the time you get to the XLAP. Patient's going to die anyway. Not true. You put this thing on, you squeeze it down, you squeeze down on the aorta, those patients actually live a little better. The data for this is going to start coming out pretty soon, but I think this is coming to an EMS near you, that these things are going to be put on, they're going to squeeze them up. It's going to look like they have a championship belt on, trying to stop bleeding, and that's okay. All right, here's our thing. ED thoracotomy, right? I still do these under the right circumstances. So blunt trauma with no signs of life, less than 10 minutes from loss of vital signs. Penetrating trauma, 15 minutes or less from loss of vital signs, right? Those are the indications. If you do them outside of this one, for blunt trauma, it doesn't really work well to begin with, right? I have a handful. I have 6 survivors from ED thoracotomies. None of them were really bleeding. They lost their vital signs from something else. Most of them had high thoracic, high cervical spine injuries, right? So they did lose their vital signs. The indication was there. Clamped the aorta, I'm feeling good about myself. They weren't bleeding, right? So sometimes that happens. You do the right thing for the right reasons, but it turns out what you did was ineffective. But I do have a handful of survivors, people. The national average is 1% survival. I have a 17% survival rate. People. So you open the chest, right? That gets the blood out, right? That gets any tension pneumothorax out. You can open the pericardium, right? So if they got pericardial tamponade, these are all life-saving measures that you can do with an ED thoracotomy or resuscitative thoracotomy. You find the aorta with your hand. You usually kind of just nudge around it to get yourself some space, and then you put that clamp on the aorta, right? So mechanical obstruction of the aorta. It's the same thing as the belt thing, but except you're opening the chest, right? You can do 5 or 6 maneuvers to try to stop the bleeding, right, or do some life-saving maneuvers. And then the last thing is the Reboa, right? You guys using Reboa here? Okay, good. Here's the thing about Reboa. All the studies say it doesn't work, and that's because they're putting it in dead people. Reboas don't bring you back to life, right? But if you're bleeding a lot and you need to do mechanical obstruction of the aorta, a Reboa is a fine instrument to do that. You can put it in zone 1, so where you want to stay away from is zone 2, right? You want to stay away from your superior mesenteric artery, your celiac artery, right? So you want to stay away from this zone. You want to be up here, right, where you're just cutting off the blood flow to everything, or you want to be down below those vessels so that you can just cut off the pelvis, right? And so that's sort of where we are for stopping the bleeding before you get to the OR or before you get to the interventional radiology suite. Main points: you got to recognize shock. You got to stop the bleed. You got to know that if you're using TXA, right, you want to give a big dose, you want to give it fast, and you want to give it to the people who are actually bleeding to death. That's where it's going to be most beneficial. And then if you're going to use plasma, right, you use plasma when the transport time is long and when it's in blunt trauma. So that's how you stop the bleed. And then thank you very much for having me.
Thank you, Dr. Hunt, for coming.
Hey,
good to see you. Appreciate the talk.
Yeah,
Thankfully, I don't have to deal with trauma necessarily anymore. But some of the things you talked about strike us in liver surgery particularly. And we use TXA for our hepatectomy patients.
Right.
And I've never quite understood the trial design that showed a gram bolus only at the start of the case was useful in major hepatectomy bleeding risk.
Really?
And so I have seen a couple of patients go and form clots kind of diffusely after TXA. And I was kind of wondering if you could comment on what you think with the higher dose. Is there a risk of that? Is there a certain patient population that maybe we shouldn't be giving TXA to or be cautious about?
Sure. So TXA in general is a very safe drug. In Europe, they give women TXA for menorrhagia. You can get a TXA prescription to take on a daily basis or during your period. So it's not a dangerous drug. If you give it outside of the 3-hour window, for sure there are thrombotic complications. But in general, for a patient that's bleeding to death, TXA is going to be fairly safe with very little thrombotic risks. Here's the secret though, and I don't like to tell people the secret because then you don't like me anymore. We don't really know what TXA is doing, right? Because if you do a tag on a patient that you gave TXA to who was bleeding and the ones who are not bleeding or didn't get TXA, right, you would think your LY30, right, your lysis of your clot should go down because that's what we think the thing is doing, is blocking plasminogen. LY30s are the same.